there is not a patient that I'm going to treat surgically or consider for any kind of surgical intervention who hasn't had a first-line medication, which generally is carbamazepine or oxcarbazepine. And it's important to do that because it's a good diagnostic tool as well. Patients with trigeminal neuralgia generally respond to carbamazepine. If they took a maximum dose of carbamazepine and they never responded to it, it's not a red flag, but it should give you pause and have you reevaluate whether or not they have trigeminal neuralgia or oxcarbazepine. Sometimes, though, some people have so much side effect or they're so intolerant of the medication that you never get a good sign. Other medications that people are often on are baclofen, gabapentin, pregabalin, or Cymbalta, or any of the other antidepressants that could help with the pain. Lots of different medication variations. But again, I like to know that they've been on either carbamazepine or oxcarbazepine and know what their response is to that before I proceed with surgical treatment. The last thing is, before I approach someone with any kind of surgical treatment, I want to do an MRI. And it's a very commonly misunderstood factor that people will say, we're looking for a vascular loop on the MRI. And with improved imaging, we can see vascular loops. We can see veins, particularly focusing on the root entry zone. But that's not the point of the MRI. I will consider a microvascular decompression on someone who doesn't have evidence of a vascular loop. What we're really looking for are other things that could be causing the pain. So it could be, a mass lesion, which could be a tumor of the trigeminal nerve. You could have a cancer that's spread along the nerve that can cause pain. You could have multiple sclerosis, which is what's imaged here. You can see as the trigeminal nerve enters the brainstem that there's discoloration from demyelination, and that's resulting in trigeminal neuralgia. So the key point here is imaging should be necessary, but it should not be to confirm neurovascular conflict, but to evaluate for secondary causes, because your approach, again, may be very different with secondary causes of trigeminal neuralgia. Now, assuming we've gotten through all that, so we've done a history, we have established that the patient has trigeminal neuralgia or has trigeminal neuralgia-like symptoms that could respond to our surgical interventions. We then talk about surgical treatments. And I, in my mind, group them into three categories. There's the microvascular decompression, which I'm sure you've heard about, which is a favorite surgery of surgeons because the anatomy is beautiful, it's very satisfying. It has risks, though, it's invasive. Then we have percutaneous treatments where we put a needle through the face to either ablate the nerve with glycerol or with a balloon, which we can inflate to compress the nerve, or we can use radiofrequency to target a specific part of the ganglion. Finally, we can do stereotactic radiosurgery. It's the least invasive of procedures, but the least effective of the procedures. And I'm going to talk about this, talk about the outcomes for that as well. I do want to highlight this slide because I speak with every single one of my patients about all of these treatments before I recommend one treatment or the other. Because patients have different tolerance. So I want to highlight that sometimes we say young patients should always have a microvascular decompression. But people have different home situations, work situations. Some people have different risk tolerance. And frankly, to jump ahead a little bit, stereotactic radiosurgery is maybe 70% effective, whereas MVD might be 95% effective initially. And MVD has a lower recurrence rate than stereotactic radiosurgery. But stereotactic radiosurgery still works in a number of people. And many people would say, well, I'll still take that. Even if it's not as effective, I'll take the lower probability of benefit because it's perceived to be, or it might be safer.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.